Thanks, Richard, and thanks very much for the invite to come and speak at this joint round. I'm the only surgeon here today, so I won't be doing any of the clever science, as you won't be surprised to hear. And I'm probably going to do a little bit of scene setting, really, for renal cell cancer. I think there probably is a revolution going on in the management of this disease now, after many years of very little happening, I have to say, and more towards the introduction of immunotherapy and its impact on overall survival and progression-free survival in, sadly, many individuals who end up with metastatic disease with this cancer. So I'm just going to present a little bit of epidemiology. This is the 7th most common cancer in the UK, reasonably high figures. Some other areas in the world it's not so prevalent, but that's its standing in the UK presently. And the European Urology Journal commissioned a review article, which was published this year in September, asking them to provide some projections around this disease and what we'd like to expect in the next 25 years. I think it is quite concerning. So those are the latest figures. In 2022, there were nearly 500,000 cases, with about 156,000 people dying from the disease. And they are predicting by 2050, the number of cases is going to go up by 72%, and the number of deaths almost by 100%. Right now, the 5-year survival figures are okay, I would say, between 40 to 75%. And that obviously depends on the stage of your disease, but also in your geographic area. And not surprisingly, some areas of the world, access and availability of treatments are not the same. Quite a lot of pathogenic variants have been identified. I'm not going to go through all of these. Some of them were well known: VHL, TSC1, MET, but some new agents coming along, BAT1, BRCA2, and a number of other that I've mentioned here. But I'm not going to go into those into a lot of detail. Maybe importantly, risk factors are being identified now. There are some which aren't modifiable. Your sex, men get this disease more than ladies, somewhere in the order of 3 to 1 on a ratio. Geographically, tends to be worse in the Western world, actually, rather than the Eastern. Ethnicity, ancestry, based on some genetic risks, and family history. But the bottom line here is much the more important. The modifiable risk factors, a lot of Western world diseases here: obesity, insulin-resistant diabetes, hypertension, chronic kidney disease, smoking, environmental exposure, not many well-known agents, but trichloroethylene is the one that's been mainly studied, and a lack of physical exercise. So a lot that can be discussed here on a preventive level, and obviously that fits with the government's agenda right now. So there are multiple subtypes. The one most commonly is clear cell, which accounts for around 75%. There's papillary, that accounts for about 10%. Chromophobes, around 5 to maybe 10%. Hybrid oncocytics, around 5%. And of a much rarer variant, the collecting duct carcinoma, which is an extremely aggressive cancer. There's a very marked spectrum of disease amongst these people. At the bottom end, we have small renal masses, which are often indolent, slow growing, may not need interventions. We have got some less invasive interventions in this day and age: robotic partial nephrectomy, and we've been providing this service in Oxford for around 15 years now. Ablation therapies, of which is cryotherapy, radiofrequency ablation, and microwave. And SABRE is starting to appear on the agenda, but probably waiting for a little bit more data on that front. At the other extreme, we have real problems. About up to at least a third to maybe half the people who we operate on, who we think have got localized disease, end up getting metastatic disease. And these are often groups with either a T3A stage or have got a tumour that's 10 centimetres or greater in diameter. They can metastasize anywhere, and some areas have a worse prognosis than others: brain, liver, for example, and bone, and multiple molecular phenotypes. So right now, I think there are 3 big challenges in renal cancer. I've alluded to these small renal masses. We still have a 20 to sometimes 30% benign pickup rate on these tumours after we've treated them, usually with surgery, and that means 20 to 30% of people are getting unnecessary intervention, over-treatment. And we're relying, I think, on biopsies, probably biomarkers and improved imaging to try and see if we can better identify these groups so we can not intervene with them. The group in the middle, I think, is probably of the biggest concern from a prognostic element, and these are the tumours that we need to better identify: the high-risk tumours on imaging, the T3 tumours, or those that have already micrometastasized. And maybe 25, possibly even up to 50% in some series of high-risk T3A renal cancers have already metastasized when they're being treated for their primary cancer in the belief that we can cure them. We're going to have to improve our imaging, and possibly high-resolution CT. PET scanning may improve this. Some markers, such as girentuximab, PSMA, may become relevant in this arena, and we will wait to see on that. We've never really had an approach of neoadjuvant therapy for renal cancer, but there are now some trials underway, and there is one study in the UK, a WIRE study, where people are getting a single agent prior to their kidney surgery, and we await to see the outcome of that. The belief being that if we can mop these cells up prior to the surgery, we might have a better chance of curing these people. And obviously, directing people to systemic therapies or SABR for oligometastatic disease rather than inappropriate surgery. And finally, and I have to say most of the talk today is around this, is the exciting introduction of IO therapies and the possibility, a glimpse into the future, that we might be able to turn this disease into a chronic disease. And we await probably data on that, but Andy is going to have a good chat about that. And Semini is going to present a couple of cases which will demonstrate what we've been seeing happen in the last few years around this approach. And then Rachael is going to give us some fantastic science at the end. So I'll hand over to Andy now.
Okay, thanks very much, Mark. So I'm an oncologist, and really what I want to talk about is, again, a bit more background, and this is more about the actual metastatic renal cancer. So the things we know about metastatic disease is it tended to be one of the more resistant diseases, particularly in the era when we were using chemotherapy. And if you go back 30, 40 years, and really with the advent and development of chemotherapy, renal cancer, melanoma, these were two diseases that really did not respond to chemotherapy. So they are thought to be some of the most resistant diseases. And actually, and I'll show you the data, with the advent of more modern-day immunotherapy and checkpoint inhibitors and tyrosine kinase inhibitors, it's really revolutionized our outcomes for kidney cancer. So this is a chart really demonstrating that. So if we go back 30 years, we really didn't have very much. We were using IL-2 and interferon, and actually that came about from the recognition that kidney cancer was not responsive to chemotherapy. And there were mouse experiments in the 1980s really looking to see the role of IL-2 and interferon. And it demonstrated that there was a small benefit in people with metastatic kidney cancer. And that was the mainstay of therapy, really up until the 2000s, when there was more molecularly directed treatment, such as the tyrosine kinase inhibitors. The first one was sorafenib, which was actually a BRAF inhibitor. And then we moved into the era of drugs such as Sutent and pazopanib. And then as more understanding of the biology of the disease came through, we developed drugs such as everolimus, as mTOR inhibitors. But the real change for how we manage patients with metastatic kidney cancer has really come around since 2015. And that was the development of the checkpoint inhibitors, which made a significant difference. And actually, the first one that we started using was nivolumab as a PDL inhibitor. And that was really first published around about 2015 in a series of patients with second-line treatments for their renal cancer. And then really since around about 2017, 2018, it's combination therapy. First of all, with combination immunotherapy with a CTLA-4 inhibitor and a checkpoint inhibitor, so ipilimumab and nivolumab. And then more recently, it's combination IO and tyrosine kinase inhibitors, such as cabozantinib, axitinib, lenvatinib. And you can see at the bottom there, the survival, the median survival, has gone from approximately 15 months in the 1990s to where we are now, median survival of 4 years. And for those of you that don't treat metastatic cancer, this is actually a significant improvement over that time. It's a big difference. And actually for us to be able to talk to our patients and treat our patients and knowing that their chances are much better than they were 10 years ago is a significant improvement. And although a lot of these patients aren't going to be cured, these drugs are making a big difference to their lifespan, outcome, and quality of life. So again, these are just some charts really just demonstrating the difference in overall survival from 20, 30, 40 years ago. And that's the chart on the left that you can see. It's a homegrown chart, but it just demonstrates the significant improvement in median overall survival during this time. And actually, when I started doing kidney cancer, probably in the late 1990s, the median overall survival for patients with metastatic disease was 10 to 12 months. And now we're talking about four years plus. And actually, the response rates as well for the treatments that we give have dramatically changed over the last 25 years, going from response rates of 10%, probably the TKIs were about 30%, probably encouraging response rates in some series, but actually not in real life. But really up to modern day, where response rates, we're looking at up to 70%. 70% of our patients will have some form of response by the treatments that we're using today, which is a significant improvement. And this is some of the data about these sort of combinations that we use. The first combination that came out was the IO-IO combination of nivolumab and ipilimumab, 2018. And actually the long-term data, 9-year long-term data has just been published from that, showing about 46% long-term survival, which is quite impressive. And then you can see the other combinations, pembrolizumab, axitinib, avelumab, axitinib, nivolumab, cabozantinib, pembrolizumab and nivantinib. And these are all combinations that gradually have just improved both response rate and survival. And actually the difficulty for us in managing these patients is what combination should we use and how do we treat and when do we treat them. One of the things we wanted to mention today is really that renal cancer is a spectrum of disease. And sure, there are some patients who present with metastatic disease that really have a very short survival, but there are some patients at the other end of the spectrum that can live for 10, 15, 20, 30 years with metastatic disease. And actually, we don't really know why that's the case. We can do molecular studies and you can look at molecular mutations in substances like BAP1, in genes like BAP1 or PBRM, but they don't really give us an understanding of why some patients have more indolent disease than others. But clinically, we can recognize that some patients who have metastases to their pancreas or their thyroid, that really denotes a very indolent outcome, very slow-growing outcome for these patients. It's quite rare, so probably in the order of 2 to about 5, 6, 7% of our patients have pancreatic metastases. And actually, typically, when they have them, they tend to have oligometastatic disease, so they only have a limited number of sites of disease. And that can appear many years post-nephrectomy. So literally, we are seeing patients that 10, 15 years post their surgery end up with a lesion appearing in their pancreas. And despite any of the prognostic models that we use, they have a significantly improved long-term outcome. So, and actually that graph basically is some of our own data on a small series of patients with pancreatic cancer, and it shows a very long survival. And actually in this series of 30 patients, I don't think we even reached the median overall survival for those patients. So what we wanted to do today is really put a background of kidney cancer. We've got some cases we're going to present now. And those cases typically in a grand round are going to be some of our good cases with good outcomes. But I think they also demonstrate the multimodality management of how we manage these cases. And then the final case is really built around somebody that had indolent disease. And that's where Rachael comes in taking some of those, some of that histology and peripheral blood and looking at some outcomes in a translational science way to see if we can understand why some of these patients with pancreatic metastases have a very long survival. So I'll hand over now to Semini, who's going to present some of these cases. Thank you.
Thank you, Andy. So yes, as Andy mentioned, I'm going to present a few cases. So these are real-world patients treated here in Oxford and really demonstrate the differences that the introduction of immunotherapy to these cohort of patients have made. So the first is a gentleman who is 57. He's previously fit and well, was working as a mechanic, presented in March 2019 with hematuria, back pain and fatigue. Now, the fatigue had gotten so bad that he was no longer able to work, so he was really quite disabled with his symptoms. No significant medical history really, a non-smoker, and he had a family history in that both of his parents had had bowel cancer. He went on to have some imaging, which I've shown here, and he had a large right-sided renal tumour, and also with a thrombus extending into the right renal vein and several lung metastases. So just to go through his treatment history, as I said, he presented in March 2019. He went on to have a biopsy of his kidney, which the MDT felt was consistent with a clear cell renal cancer. And then based on the back of Checkmate 214, he was treated with combination immunotherapy with ipilimumab and nivolumab. So he had these two immunotherapy drugs together. And after 2 cycles, he had a repeat scan, which actually showed what looked like progression was reported as disease progression. I'll show you some pictures in a minute. Now, this is something we sometimes see in immunotherapy. We see what we call a pseudo-progression. It happens in about 10% of patients on immunotherapy. And actually, although it looks like the cancer has grown, what we think is it's actually just immune infiltrate, so an influx of T cells, B cells into the cancer, which looks on imaging like progression. And it's really important that we recognise this as a phenomenon so we don't stop treatment prematurely. His next scan, so a couple of months later, went on to show disease response. So he carried on with treatment. He had the 4 cycles of the combination immunotherapy, and then he went on to continue maintenance nivolumab alone. So that's a 4-weekly injection that he carried on having. He was tolerating this very well and had ongoing disease response on his scans. So this is December 2019. He carried on like this for nearly 2 years. So regular monthly injections, 3 monthly scans, ongoing response, up until October 2021, when, although he was responding in the lungs, that looked like there had been some local progression. So we think a clonal progression in the renal cancer. And this was discussed in our MDT. And he went on to have an open right nephrectomy and IVC thrombectomy, which I understand from Professor Sullivan was quite a tricky surgery. But actually, and I'll show you some of the slides from the pathology, there was very little to see in the way of tumour when we looked at this under the microscope. So this was all removed. He carried on his nivolumab. There was no evidence of any active disease now on his scans, and he is still continuing on immunotherapy now. So he just had cycle 75, I think, of nivolumab, and he has no evidence of disease on imaging. So he is living great quality of life, coming in 4 weekly for treatment. We now give this subcutaneously, so it is literally like a 5-minute injection that he has and goes home and carries on living his life. So that's from March 2019, so over 6 years of response there. If we look at his imaging, so this is the first picture I showed you with the large right renal tumour. And then, it's not a great picture, sorry, but it shows that the cancer had actually increased from 12 to 16 centimetres on treatment. And that's that pseudo-progression I was talking about. If you look further down the line, the tumour had shrunk really nicely down to 6 centimetres on that scan a couple of years later. The same with the lung metastases. So on the left-hand side was his original scan. The second scan showed some increase, so it increased by a few millimetres, again, in keeping with that pseudo-progression, but now there's no visible metastases at all in his lungs. So he's had a fantastic response. Looking at his pathology, thank you to our histopathology colleagues, Maria, who's been really helpful in getting some slides for us. So in the original biopsy, we see that there's a tumour showing lots of eosinophil cells. There's eccentric nuclei, and the MDT felt that this was consistent with a clear cell renal cancer. And then if you look at his nephrectomy sample, so these are the same H&E stains, same magnification, and there's quite a difference. There's very little tumour cells. We see tumour necrosis. There's some ghost cells on the right-hand side, and dystrophic calcification in the top corner, which are all signs of response to immunotherapy, and we see that immune infiltrate in his nephrectomy sample, reflecting that response. The second patient, again, a gentleman in his 50s, previously fit and well, no significant medical history. He presented a little later, so January last year. He had hematuria, flank pain, and weight loss. And he was taking just codeine for pain, the flank pain that he was getting, and he was quite symptomatic with this, but no other medication. Had a sister who'd had skin cancer, but no other family history. And he lived with his partner. He was a heavy smoker, which we often see. He had a CT scan, which showed a smaller tumour this time, a 6.5 centimetre tumour, but there was also evidence of lymph nodes and mention of possible lung metastases. And he went on to have a renal biopsy. I've got the whole report here, which obviously you don't have to read, but this is really just to highlight that there was some diagnostic uncertainty, and the conclusion was it presents a challenge. We discussed this in our MDT, and actually based on the aggressiveness of the cancer, the imaging, we felt it was in keeping with a clear cell renal cancer, and he also went on to have immunotherapy. So he presented in January. The MDT decision was to treat as a renal cell cancer, and he commenced ipilimumab and nivolumab as well. So combination immunotherapy. He was quite symptomatic at the beginning, so he was requiring a lot of palliative care input for help with his symptoms. And he started treatment, and was admitted not long after with shortness of breath, was found to be COVID positive. He had a CT scan at this point, which was reported as stable. Actually, we reviewed this in our MDT, and we felt that although the renal cancer itself was stable, the tumour was stable, the lymph nodes had actually improved. They were now sub-centimetre, so there was very little to see in the way of disease. He carried on with nivolumab alone, so he completed the 4 cycles combination, carried on the nivolumab maintenance, and he began improving a lot symptomatically, requiring much less analgesia. He became hypothyroid. That's something we see quite commonly on immunotherapy, but was generally tolerating treatment very well. His scan at the beginning of this year still showed stable disease, and so actually all we could see was that 6.5 centimetre renal tumour, which hadn't really changed radiologically on treatment. And we discussed this in our MDT, given that it was stable disease, whether he'd benefit from a cytoreductive nephrectomy, which he went on to have in September of this year. And actually, under the microscope, there were no tumour cells seen at all. So this cancer had responded completely to immunotherapy. We took out what essentially looked like a normal kidney. And even though on imaging, it still looked like there was tumour present. He carries on nivolumab. He's tolerating it really well and also having a good quality of life with no evidence of disease on his most recent scan. This is his pathology, so that's his kidney sectioned and bivalved, and there's no visible lesions there at all. And again, on the H&E, you can see there's no completely regressed tumour there. So these 2 patients have had a really fantastic response to immunotherapy. As Andy said, we're presenting the good ones. But this third one is a little bit different. So this is a gentleman who was diagnosed in 2003, so before all these treatments were available. And he presented at 52 with 3 stone weight loss, was lethargic, had indigestion and anemia. No significant medical history, family history of father with prostate cancer, and his paternal grandmother had had breast cancer. He was an ex-smoker, but not currently smoking. He had a CT scan, which showed a large 15 centimetre left renal tumour, but no disease elsewhere. He went on to have a nephrectomy back in 2003, which showed a PT3A tumour, but no nodal involvement, although there was some vascular invasion. So he, as there was very limited treatment options then, he entered a period of surveillance. And he was doing quite well until January, a couple of years later, when he had a visual field defect and was found to have a brain metastasis. That was the only site of disease, and it was resected, and the pathology was consistent with a renal cell cancer having spread to the brain. He carried on because we felt that the risk of more metastases in the brain would be quite high. He went on to have some adjuvant radiotherapy to the brain. So we had 30 gray and 10 fractions of cranial radiotherapy to try and prevent further brain metastases. The next year, so another year passed after that, he had what looked like relatively low volume recurrence. So he had 2 centimetre hilar node, a couple of bone mets, and what looked like possible recurrence in his renal bed. But given he was not really symptomatic and there were limited treatment options, we carried on with surveillance. However, a bit later that year, a couple of months later, he started having pain in his right leg, was found to have a lytic femoral lesion, which he had nailed and had some post-op radiotherapy to this and also to his spine. So that was May 2006. A little bit later that year, it was clear that the disease was progressing. He had I think a supraclavicular lymph node. And so now we had sorafenib available, which is one of the early TKIs that was used in renal cancer. And he had this from October 2006 to June 2007 with some effect in terms of disease response, but it really impacted his quality of life. He was having diarrhea, rash, fatigue, sort of bad hand-foot syndrome, which is something we see, and really wasn't getting on with it. So although he was responding, he stopped the drug in June the following year and carried on surveillance. He then had quite a few years without anything significant, but then had an enlarging thyroid nodule found in November 2010, which was removed. He had a right thyroidectomy, which also consisted of the pathology with metastatic renal cancer. Another few years goes by, and then on some surveillance imaging, he had some pancreatic metastases noted, and these were kept under surveillance. A couple of years later, he gets diagnosed with prostate cancer, Gleason 7, but this was just kept under surveillance. And then a few months later, he was found to be anemic, and that wasn't obvious on his CT imaging why that was. He went on to have an endoscopy for investigation of anemia. We found that there was a mass at the head of the pancreas invading into the duodenum, which was oozing, explaining the anemia, and a biopsy of that confirmed renal cell cancer. And he went on to have some palliative radiotherapy to the pancreas. So he had 20 gray and 5 fractions of radiotherapy. That kept things under control for over a year, but then he had some further bleeding, and it was evident on imaging that his pancreatic lesion was increasing. And so he went on to have surgery. A few months later, he had a total pancreatectomy and splenectomy. Again, the histology was consistent with an RCC. So that surgery was done 16 years after his original diagnosis. And the operation, I believe, went well, but a few weeks later, after discharge, he was admitted having had a fall at home, thought to be secondary to an aspiration pneumonia. Unfortunately, had an extradural hemorrhage and had seizures, was admitted, and he died. So it's quite a different case, this one. It's 16 years. It really highlights the indolent nature of the disease that we see in some people. He actually died not from his renal cancer, but from complications after surgery. And if he'd been diagnosed today, we probably would have treated him differently. He may well have had some immunotherapy and more systemic treatment like we saw in the first 2 cases. But he did have lots of surgeries and multiple tissue samples, which have allowed further research. And that leads me to introduce you to Rachael, who is going to show us the wonderful stuff she's done with lots of his samples.
Thank you for introducing this. And so we don't need to introduce this case, but as we already know, there's a high unmet need, particularly in metastatic renal cell carcinoma. And we were very interested in this elite survivor to understand what was going on here, why did they have such exceptional survival, and we were very interested in particularly understanding the immune response. So this work was led by Dr. Felicia Tucci, where we had access to the year 0 samples. So this was the diagnostic samples from the original renal cell carcinoma and its draining lymph node, along with the year 16 tissues from the metastatic pancreas, the draining lymph nodes from there, both as FFPE and also fresh tissue. So if we compare between the year 0 kidney tumour and the pancreatic and metastatic tumour, we can see evidence of tertiary lymphoid structures. So these are the clusters of B and T cells that come together to activate each other and hopefully elicit an immune response. So what we can see in the kidney tumour at year 0 is that we have actually some very large tertiary lymphoid structures that almost look like active germinal centres, and these are within the tumour, whereas the pancreatic metastatic tumour at year 16 shows these tertiary lymphoid structures typically at the side of the tumour, never really infiltrating into it, and they were much smaller. And in fact, we can see that there's a significant difference in the total size, total number of cells of these tertiary lymphoid structures between these two sites and time points. So what we could do, given that we had the samples from both year 0 and year 16, is that we could do B and T cell receptor sequencing. So the really lovely thing about the adaptive immune system is that B cells and T cells have these adaptive immune receptors, BCRs and TCRs, and these are derived from VDJ rearrangements that allow them to have antigen specificity and expand upon antigen activation, antigen binding and activation. So we can use these VDJ rearrangements as molecular barcodes for these clones, and we can sequence them to understand the dynamics of these populations. So what we did is we combined both bulk B and T cell receptor sequencing along with single cell multiomics, which allowed us to capture similar sequencing. And what we could see is between both the year 0 and year 16 time points for both B and T cells, B cell clones, is that we could see clonal persistence across these sites. So not only do we see B and T cell responses shared between tumour and draining lymph node, but these were persistent across 16 years of the patient's history, suggesting that there's durable adaptive immune engagement and continuous trafficking between sites and immunosurveillance. What we can also do is from these B and T cell receptor sequences is we can try and understand the dynamics of these. So apologies for the resolution here, but these networks here are essentially family trees of expanded B cell clones within this patient. So each dot is a unique B cell receptor sequence, and they're related by somatic hypermutation that can increase or decrease the affinity to the antigens that they're being selected against. And they're color-coded according to which site and time point they were seen at. And as you can see, we have affinity maturation, so somatic hypermutation across time and across space. And we also see that there's evidence of continued antigen exposure and iterative mutation over time. So, and we also see highest levels of clonal diversification, particularly in the lymph nodes of both the kidney at year 0 and the pancreas at year 16. So this is an incredible insight into understanding persistent long-term immune cell responses. Because we also had this fresh tissue, we were able to do single-cell multiomics, which allows us to capture both the gene expression as well as the B and T cell receptor sequence on individual cells. And what we can do is understand the diversity of immune cells that have infiltrated into the pancreatic met, as well as the blood samples at year 16. So this is just a representation of the diversity of different immune cells. So basically, there are thousands of dots here that represent individual cells, and they're closer together if they're transcriptionally more similar to each other. And if we zoom into the B cells, we can give high confidence annotations of what types of B cells these are and from which sites they come from. And using the B cell receptor sequencing information, we can also understand the clonality. So this is a B cell receptor network map. I'm sorry. What have I done? There we go. That's better. So basically, each dot here represents a unique B cell receptor sequence or antibody sequence. The size represents the number of cells that we observe with that sequence, and they're color-coded by where the cell comes from on the left. So whether it comes from the blood in red or whether it comes from the pancreatic met in green. The isotype associated with each B cell, and also the cell type. So it's the same network, but color-coded differently. And what we can see is there were two highly expanded clones within this patient at year 16, clone 25156 and clone 298308. And when I say highly expanded, These represented over half of the B cells within the blood and the tumour of this patient. And it makes me think it's a leukemia, but they didn't seem to have a leukemic phenotype. They had a memory cell phenotype, very much consistent with what we've seen in other data sets. So you see this significant level of B-cell clonal expansion in both the blood and the tumour, the pancreatic tumour site. And we can see that these clones are going in and out of the tumour site. Because we have linked gene expression of these single cells, we can look at clonality. So what we can see is, across several measures of clonality, is that the highest level of clonality is for the B cells is seen in the conventional memory B cell compartment. And for the CD8s, we see CD8 memory as significantly higher than the rest. So this is what we would expect for an immune response that's directed against a tumour. So what we wanted to ask next is, we know that we have these massive B and T cell clonal expansions within this tumour, but where are they sitting and what are they doing? So what we did, with Felice, we designed RNA probes to be able to see exactly where the RNA encoding for these B and T cell receptor sequences are sitting within the tissue using a base scope technology. And essentially what we can see is these probes allow us to visualize two RNA sequences at once. So for example, in this image at the bottom from the pancreatic draining lymph node, we can see the heavy and light chains in red and blue. And we can see that there's extensive infiltration of the draining lymph node of this highly expanded B-cell clone. And for the second most highly expanded B-cell clone, we can see some limited examples within the draining lymph node. So we can see for both of these, there's extensive migration between the pancreatic met, the blood, and its draining lymph node at year 16. Next, we wanted to understand if these highly expanded B and T cell clones are actually interacting with each other and potentially co-activating each other. So what we did is we developed a new approach using the single cell sequencing data to basically pull out doublets. So we used 10x single cell sequencing approach, which basically encapsulates single cells within droplets to be able to then barcode the transcriptome of those cells, and then you can pull out that information bioinformatically. But what happens is that some of these droplets encapsulate 2 or more cells, and we can actually pull that out bioinformatically. So for example, these droplets encapsulate both a BCR and a TCR. We know that a B and a T cell must be sitting within that. So what we could see is we have these doublets, so these physically interacting cells that we could find in the single cell data. And we could see that these B and T cell interactions were enriched for our highly expanded B cell clones, so our largest and second largest clones. So it suggests that these clones are actually significantly enriched for interactions with T cells. And we can see that the T cells that predominantly interact with these highly expanded clones are CD8 memory T cells, and they have a preferential V gene usage, suggesting that these are actually antigen-specific T cells, possibly antigen-driven pairing. So what we did is we designed some additional base scope probes to look to see whether we do physically see within the tissue these B cell and T cell clones interacting, and that's exactly what we can see. So from the single cell transcriptomics, we predicted which B and T cells would interact, and we can see that directly within the tissue. And we can see that these CD8 T cells and B cells are physically interacting, making immunological synapses, as we can see here at the bottom. So this suggests that they are involved, actively participating in local immune responses. So the next question we wanted to ask is, now that we can see these large clonal expansions, B-cell clonal expansions expanded within the tissue, we can see migration across different sites. We actually see these highly expanded clones all the way through the patient history. Well, what are they responding to? So what we did, we expressed some of the antibodies that would have been expressed by these B cells, as well as some of the germline revertants. So these are the equivalent antibodies, but without any of the somatic mutations. So these were selected on the basis of clonal size, and we wanted to see what these intratumoral B cell responses were targeting. So we did this by a couple of different methods. First of all, we checked the binding of these monoclonal antibodies against fixed cell lines. So we chose a renal cell carcinoma cell line, a pancreatic cell line, and an HKC8 cell line. And what we can see is that MAB4 seemed to be reactive against all three of these cell lines when fixed, and we had a very low level of reactivity by MAB5. If we did staining with live cell lines, we can see that MAB5 had a very strong reactivity against the RCC cell line, and pretty much exclusively to that and not the other cell lines. And then we also did imaging against tumor tissue. So using these monoclonal antibodies, we stained patient tissue and saw that there was actually some reactivity of MAB1. So this was actually coming from the most expanded clone within the patient. So this work shows that the clones that are recognized by tumor-infiltrating B cells were of different flavors. So MAB1 binds patient tumor tissue, MAB4 targets intracellular tumor antigens, and MAB5 binds live tumor cells through extracellular tumor-specific epitopes, including antigens that are shared across unrelated RCC tumors. So there are a lot of different reactivities that we can see here. So we can show that tumor-infiltrating B cells are functionally antigen-specific. So the next thing we wanted to do is test MAB4 and 5 to see if they would actually bind unrelated patient tissue as well. So here we can see that the staining of MAB4 and 5 against adjacent normal and also from the RCC of unrelated patients. So our most reactive monoclonal antibodies strongly binds tumor cells, including from those of other unrelated tumors, but shows negligible binding to normal tissues or irrelevant cells. So our final question here was, what was the target of this MAB5? So what we did, what Felicia optimized very, very nicely, was to basically do a flow sorting experiment using the RCC cell line that we had to separate MAB5 bound cells versus those that didn't bind. And then we perform plasma membrane extraction and then put this on mass spectrometry. And what this gave us was, first of all, a very nice plasma membrane detection. So we've identified 3,200 odd plasma membranes across the samples. And we could see that IH3 was identified as a candidate antigen for intratumoral MAB5 binding from an intratumoral B cell. So this nicely shows that there's an incredible immune response in this patient. So we see tumor-infiltrating B cells across that were functionally mature and antigen-driven selection. Expanded clones produced BCRs, or antibodies that directly recognize tumor antigens by a number of different mechanisms. The humoral response was highly adaptive, tumor-specific, and not just bystander infiltration. The B cell clones evolved over time, increasing position towards tumor antigens, and most intratumoral B cells were memory, not actually antibody-secreting cells, suggesting a key role in antigen presentation to T cells, and that's exactly what we saw with the imaging. So we saw these extensive clonal expansions. We show clonal persistence. We show these germinal center-like reactions, where these highly expanded B cell clones activate CD8 effector T cell responses, and we show that the B cell responses are tumor specific. And this reveals some interesting mechanisms of anti-tumor B and T cell responses. So we're developing this a lot further. So we have a really nice program looking at long-term pancreatic ductal adenocarcinoma survivors, and we're hoping to take the renal cell carcinoma project further. We're also looking at cross-pancreatic pathologies, so trying to understand how the pancreas is actually reshaped by different diseases. We're developing a lot of methodologies to try and understand both the spatial clonal interactions and also developing novel multi-omics methodologies to address some of the key questions in this area. So I do have a lot of people to thank along the way.
That's great, thanks Rachel. So just finally, I hope we demonstrated several things. One is that we can't manage our patients with kidney cancer without multiple specialties being involved. I think we've also demonstrated that over the last 20 odd years, that treatment has changed massively and there's been a huge improvement in outcomes without any doubt. For those of us that trained a long time ago, renal cancer today is not the disease it was 25, 30 years ago. And I think we'll also demonstrate that every patient we treat is interesting and that combining the science, every patient really has a story and the science demonstrates that. And I think the other thing we've demonstrated is there's a lot we don't know. Thank you.
Okay.